what we're focusing today is on the first and the third part. So this is a patient who comes to your clinic, you do the Adams forward bending, you see something, and what you all can't appreciate at the thoracolumbar junction or slightly higher is what is happening there. So in these children, it is absolutely necessary to have a CT scan just to know the anatomy of the vertebrae, and here you can see he has a hemi above and a butterfly below. So this is where CT is of utmost importance, where you cannot understand the actual anatomy, especially in these kids who are triform scoliotic at an earlier age, less than 10 years. Coming back again, this is a classical primary spondylodiscitis. The CT actually shows the void which is present. So this patient actually underwent an in situ fixation without any grafting, without any reconstruction. Now that is his X-ray at 2 years, but you need documentation of the CT just to show that it has united without putting anything inside the space, without debriding, just taking tissue culture and biopsy. What it also shows at 4 years is that there is autofusion posterolaterally as well. Okay, this is why CT is important to document fusion. So now this is another case where, like majority of the tumor that Agnivesh also showed, this is a giant cell tumor of the C2 where we put her on a halo, which was necessary because there was nothing at the C2 level. Then we started her on denosumab, and you can see how the sclerotic rim is entirely formed and it is filling up the odontoid. Now what happens is we put her to 20 doses of denosumab over 3 years, and this is her X-ray with complete functional recovery, and so far we've stopped her denosumab. The point I tried to make here is that Goriani, I think this patient was during my fellowship in around 2018, and the Rizzoli group or the Milan group came up with a classification where you classify these lesions after denosumab treatment on CT scans. And then later in 2019, he started grading these things at 6 months interval. So this is why CT is important also to know how well your denosumab works. This is another case. It was an RCC met at the thoracolumbar junction. Now, whenever you have a pathological fracture, obviously after an MRI, you need a CT scan just to see from which side the tumor is behaving aggressively, from which side is the tumor encroaching. Not only does it help you, but it also helps you to plan your surgery. Like if I am to plan this, I know there is a void in the lamina because there is an extensive soft tissue involvement. So I'll be very careful by starting from the contralateral side before jumping onto the ipsilateral. So going further, this is again one of those X-rays which Manish also showed. So there's something going on in the L2. The MR also had few telltale signs of it going towards the hemangioma side, because it is not exactly showing that it's a hemangioma, but this is something which is very rare, that it had honeycombing on the CT scan, which is a telltale sign of a hemangioma. More importantly, what is even rare is that there's a pathological fracture within a hemangioma, which you don't often see. So this is where the CT is actually very important, because a lot of surgeons, as we have advanced over time using various things, in hemangioma they go ahead with a vertebroplasty, but if one is not aware of this, if one is not aware of the pathological fracture here, you can actually have an extravasation of the cement while pushing in cement. Coming to some pain management modalities, so again, like Siddharth had said, that this is an elderly lady with a right-sided post-auricular and an occipital pain. These were her facets. If you see the CT scan, there is significant arthritis on the right side. So this is one of those patients where we managed with a block at the C12 facet joint. This is very important because this is something which I had taken up as my research topic. So we had studied some 400 percutaneous screws which were cement augmented, and what we did is we zoned them out in distribution. So when we do a CT scan, this is where, and this is how we kind of, you can actually know where your cement is actually distributed in whatever zone. However, also it shows whether the cement is concentrated or diffuse. What I mean by that is, in patients who are very porotic, there is very much thinned out trabeculae. So whenever you try and push cement, it kind of spreads. It never percolates at the same level. So we had actually had an association where the concentrated part, the cement which just accumulates around the screw, is more like a concentrated distribution. But people with lower BMD, it just scatters around. So the CT scan will also show you the distribution of cement and whether there is any retropulsion or retrograding of the cement when you push it. Because not all fenestrated screws have that have the fenestrations in the anterior third. Some even have in the mid third. Again, CT scan, no-brainer for whenever you attempt a revision spine because you want to know your bony landmarks. Now that patient had come with a pathological fracture elsewhere, they just decompressed it only to realize that it was a thyroid met. Now she comes to us with this picture and you should know what are you dealing with. You should know your bony landmarks before even attempting these surgeries because that would actually help you and ease out your intraoperative skill. So this was a PJK which we had, a 2 to 5 fusion was done. Now the patient however couldn't do an MRI because she also had an ipsilateral femur fracture and the MRI guys there said, okay, no, we're not going to do. In such scenarios, a CT myelo is extremely helpful. So this is where she underwent a myelogram. Not only did she have that osteophyte anteriorly on the CT, she also has some faint amount of OLF. Okay, so there is something from behind as well. So this is like a choked up compression with which she had come. So in the absence of an MRI, a CT myelo will always give you a better picture. Even when you have a degenerative disc disease which has been operated once, twice, and then if you actually want to identify the pain generator, you should have these CT myelos in flexion and extension to actually know where the dia is not flowing. Again, now if you've put screws, you may have infection. Infection is much common. So as you can see, something which is doubtful on an X-ray, when you know that she's come back to you with pain, you have ruled out every other thing. Now you see figure B. There is some lucency around the screw. Can you see? The same thing below is the level below where there is no lucency. So around the screws there is lucency. You may suspect either screw loosening or some infection in such scenario, and that will help out to gauge your further algorithm easily. Again, a screw lysis of a lateral mass where there is lysis of the entire thing and the screw is kind of backing out. So just to wrap this up, it remains an important modality in managing majority of the infective, pathological and even deformity cases in spine. CT scan also plays an important role in degenerative spine surgery, especially assessing fusion, all those T-lifts and posterolateral fusions that you do. And it is also an important tool in revision spine surgeries, aiding the surgeon intraoperatively. Thank you.